I don't know if everyone's listening, but Miss Laura just postponed the test and exam until Monday.
You got to be kidding me.
Sorry about that noise. Postpone the test? You mean I don't get to take a test on Monday? Oh, man.
I think they give us 4 tests on Monday now.
Oh, that is true. Because you guys got 2 of them with me on Monday. Oh, dear. You guys running behind in the class or what?
We had a meeting today, and we were supposed to have it today, so.
Gotcha. Well, that does happen sometimes, but it's doable. It is doable. Just gotta pace yourself. Don't burn yourself out. Pace yourself when you're studying. You can do it. Good thing is the test in this class is a very short chapter, not a ton of information. So it should not be a very hard test, at least in this class. Rad Pro do study a lot. It's a lot of information in that class. Okay, so I'm running a little bit late, guys. I just had to do a quick meeting with my daughter's teachers. 504 meeting. Just got all that, but we're about to get started here in just a minute. Make sure we got everyone logged on. Please have your cam on if you do not already. Excellent, excellent. Okay, so let me go ahead and get the PowerPoint pulled up. There we go.
Wait, so this means that we don't have that 10:45 class then? We don't have to do anything. We don't have to, right?
Wait, I'm sorry.
We don't have class because
Yes, as far as I know, you guys still have your 10:45 class, unless you've been told differently by Miss Laura. She said you guys will not have class.
Well, was she supposed to be having her meeting at that time? Because Ms. Bourne was supposed to proctor the exam?
But if she canceled the exam, does that mean that we don't go into class?
That's a good question.
Mr. Donahue proctored the exam so that we can just take it and still have 3 exams on Monday because.
Can I just pre-train? I'll tell you what. Let me send her a text right now. You see what's going on. Let me see if she texts me back. Okay, while we're getting this lecture started.
Mr. Donahue can proctor the exam. We'll be good. Fine and dandy.
She can just trust us. Just give us the code. Our system.
We agree, John, and we agree.
Hang on, I'm texting her right now. I'll see if she responds back.
Now the package. Oh my god, I just cracked it open and I have an idea what it is. Notes first, cuz manners. Also, can you take them off?
All right. If she texts me back, I'll let you guys know what she says. All right, so chapter 19, everybody. This will be a discussion on non-aseptic techniques, a very short chapter. We're not going to go over a ton of new information. So we learned about aseptic technique. Amy, I'm sorry, Amy, are you talking about my class or something else?
No, Ms. Laura, I'm sorry.
Okay, no problem. Just making sure. Okay, she just texted back. No class, guys. No class, no test for 10:45. You do have mine at 1 o'clock. It's not changing. So. All right, let's get to non-aseptic technique here. So we did learn about aseptic technique. So in your own words, what do you think non-aseptic technique refers to? We'd like to define that. Very easy definition. Well, everybody speak at once. It's not a trick question. So if aseptic refers a lot to sterile technique, what do you think non-aseptic refers to?
Non-sterile technique, we don't have to be as clean. Not wouldn't say clean, but as disinfect everything compared.
There you go. Basically, the simplest definition of that term, guys, is it's procedures that do not require sterile techniques. And we're going to go over a few distinct procedures today. We're going to go into a little bit of detail of what they are, because all these procedures we're going to talk about today are procedures that you will be involved either directly or indirectly at some point during your career field. With that being said, these procedures we talk about today would all fall under the non-aseptic technique territory. In other words, they're not going to be something that needs that sterile technique. You can simply use regular gloves. We still are always going to wash our hands, but regular plain latex gloves would be appropriate for these different procedures that we're going to talk about here today. One more time, that non-aseptic technique are procedures that do not require sterile technique, versus aseptic being ones that do. And here's just a little overview. I don't know why my little computer bar is showing up here. There we go. All right, so the few procedures that we're going to be going over this chapter, guys, we're going to start with nasogastric tubes. Shortened version would be what we call an NG tube, something we're actually very directly involved in, whether we're actually inserting that tube or providing the eyes for the nurses and the doctors when they insert those tubes themselves. A lot of our patients do present in the hospital with these NG tubes. It is something that we do a lot of x-rays to confirm the placement on. So we're going to go over a little bit of the process. We're not going to go extremely into it, but we're going to go about that process a little bit. And we're going to talk about some of the kind of x-rays we might acquire to make sure we're confirming that NG tube is placed properly. But that would be a non-aseptic procedure that we are involved in. Urinals and bedpans. You might be saying, whoa, I did not sign up to work with urinals and bedpans. Isn't that the nurse's job? It is the nurse's job, but it's also your job, because there are times when you will walk into a patient's room or they come into your x-ray room, and guess what? They got to go to the bathroom. And every x-ray room should have urinals and bedpans on standby, just in case that does happen, especially if they're non-ambulatory. Does anybody know what non-ambulatory means? What does ambulatory mean?
They can't walk.
Ambulatory
They can't walk. They can't walk. They can't get to the bathroom. So what would you have to do as a tech? You're not going to say, hey, you just got to hold that in until you get back to your room. I'm sorry. Deal with it. No, you would never say that. You're going to provide the means for that patient to be able to use the bathroom properly within your x-ray room, or if you walk into a patient's room with your x-ray machine doing a mobile x-ray, you're going to provide the services to help them use the bathroom properly, and that would also be considered a non-aseptic procedure that we're involved in. And then we're going to end on this chapter on barium enemas, a very popular procedure that we are very involved in. It's one of your competencies, as a matter of fact. We're going to go a little bit into the details of what's involved with that, and I do have a very fun story on that subject to share with you guys. That's to do with my very first day as x-ray tech when I was assigned to the barium enema room. But we'll wait on that story for a few more slides. Very fun story. Not from my perspective, but everyone else finds it fun. Funny, more like. Okay, so NG tubes, everybody. So nasogastric tubes. They are made of plastic or rubber, and we are going to use what's called a 14 or 18 French tube. When you see that F, that capital F that's referring to French, an NG tube is labeled in size by the French. So it'd be a 14 to 18 French NG tube that's inserted into our patients. It is directly inserted into the nasopharynx all the way into the stomach. And we always got to confirm that it is in the stomach. There are multiple ways we do that. We're going to talk about that here in just a second. But that tube must be advanced to the stomach. It cannot be advanced only to the esophagus. It cannot be advanced beyond the stomach, because that can occur if we don't know what we're doing or we do not do it properly. And there are instances when you as a tech, depending on the procedure you're involved with, you may actually have to insert a nasogastric tube as well. I had to with a lot of pediatric patients, because in pediatrics, if you can imagine, a lot of children will come in, especially infants, and we got to do something like an upper GI exam, which will involve them swallowing barium. Well, a baby's not going to swallow barium if you tell them to. They can't understand that. They may take it from a bottle, they may not. In the instances where they cannot, or they just don't understand, or even an older child that may not understand or cannot physically swallow, we would advance that nasogastric tube and push the barium through the tube into the stomach to still get that same procedure done. So yes, as techs, there are instances where we would have to administer or put these nasogastric tubes in, even though most of the time nurses will have that taken care of for you, but that isn't always a guarantee. So we will learn how to do that. You will learn to do that in your training as well, how to do that properly in case you are in that situation where the nurse has not put the NG tube in. You got to get that patient ready for that GI procedure or whatever procedure you're doing. Okay, so what are they used for? These three main reasons right here. That's going to be the administration of medications. And I would write there as a note, guys, when we say administration of medications, that does include contrast. Contrast is considered a medication, and we in radiology administer contrast mediums. Why? Of course, to light up the organs, to light up the anatomy we're trying to see within the digestive tract. It's also going to be used for gastric decompression, or to simplify that, the removal of flatus, which is also a fancy way of saying gas. A lot of times patients will get extreme gas in their stomachs and their intestinal tract. We can put those nasogastric tubes in and actually draw that gas out if they can't eliminate it by natural means. And that is needed a lot in pediatrics. A lot of babies will swell up quite a bit, adults too. And we got to go in there and remove that gas by pulling on that syringe. We put the syringe on the end of that NG tube, pull that syringe back, remove that gas, and give that patient some relief. And of course, removal of fluids from the stomach after intestinal obstruction or major trauma. There are many injuries, many conditions where the patient's insides or stomach specifically will fill up with fluids. They're going to use that NG tube to draw back on those fluids, just like with the air, pull it out to give that patient some relief, because much like the gas, extreme fluids are going to cause that patient to inflame, swell up, get very large in their abdomen area. We got to go in there and pull that out very quickly. Most of the time that will also be done by the nurse, but there are instances where you may also be doing that as well, especially if a patient comes in with a lot of discomfort. They have an NG tube in. You need to go ahead and pull back on that syringe, remove that fluid, and give them a little bit of relief. And sometimes the doctor will ask you after a GI procedure, for example, where an NG tube was put in the patient, he may want that contrast removed. He may not want that contrast to go through the whole system of the patient. He may ask you, can you go ahead and draw the contrast back out? At that point, you would put your syringe on that end of that NG tube, pull the contrast out of the patient as much as possible, and eliminate it that way, instead of letting it go through the natural digestive process. So many different instances where this tube is going to be used, even for you guys as technologists, it happens quite a bit. Now, we do have a special type of tube. It's called the Dobhoff tube. That's going to be the most comfortable and most flexible tube and the most commonly used tube of all the NG tubes. It's called the Dobhoff tube. So that'll be the most common one that we see in the hospitals. That's the one I've worked with the most as well. In fact, it's the only one they had where I worked, that Dobhoff tube, because it is very flexible. And as you can imagine, it's a very uncomfortable thing to have in your body. This is considered the most comfortable type tube to have within the body, because patients aren't sedated when they have these tubes in. They're sitting there like you and me, and that tube's down their throat. It's constantly making you feel like you got to gag, you got to choke. I mean, I've never had one, but I can imagine that would be driving me insane, feeling that in the back of my throat constantly. But that particular tube right there is what they claim to be the most comfortable. And of course, the most flexible, which is important, because as we're moving that tube down the patient's esophagus into the stomach, it needs to be flexible, otherwise it's going to get caught up on the esophagus. It could tear it, it could injure it. And it needs to be flexible within the stomach as well to make sure we're getting it in the correct area of that stomach, which we will check in multiple different ways. That is the Dobhoff tube, most common one we use in the hospital environment and clinics.
Okay, can I say something?
Absolutely.
Oh, so I've had a gastric tube in me, and I don't like it at all. It's the most uncomfortable thing ever.
So you can confirm what I'm saying, that probably makes you feel like you constantly got to gag and choke?
Yes. I mean, like, every time I try to drink water, yes.
So you would not recommend getting an NG tube, I'm guessing, right? It's, it's not on your top list of recommended procedures. No. I mean, I've never had one, but I can only imagine, especially if you're a person with a really bad gag reflex, it seems like that would be even worse. So
It's when they put it in.
yeah. And put it in while you're awake, guys. That's the thing. Did they do that for you too, Tracy? You were awake when they put it in? Yeah, you're fully aware of what's going on when they put that tube in. And they're telling you to relax and swallow to help it advance. And I've seen it over and over again. People just like choking, and sometimes they vomit. It's not fun. It's not fun, but necessary, unfortunately. I appreciate that, Tracy.
Mr. Donahue?
Yes.
Okay, so you said that sometimes we're going to have to do this, right? But
Yes.
how are we going to do this if we don't have a stethoscope? Because we need a stethoscope to hear for the sound.
We're getting there. You jumped a little ahead. We're getting there, though.
Oh, my bad.
No, that's okay. That is one of the ways we check for it. I think you had some future vision there, because that's on one of the slides coming up. We're,
See, it's hectic.
hey, that's all right. So as far as with when we're transporting these patients, guys, and yeah, you're going to transport these patients. Sometimes you help transfer patients. Sometimes you move them from the room to your X-ray room. Whatever. We always have to make sure that NG tube is very secure. We'll add the word very secure to the patient's nose. And how do we do that? We apply what's called a duoderm. That's what we see right here. Duoderm is a special kind of tape. You don't want to use your normal tape. You want to use a specialized tape to keep it adhered to the skin. You know anything about tape? If a person sweats, a lot of times tape or Band-Aids will come loose. That duoderm is going to stay fastened a lot more securely. And imagine for a second, it doesn't matter if it's an adult or a baby, but babies especially, they're going to feel something in their nose. What are they going to do? They're going to reach up and try to pull it out. The last thing we want to do is have that tube pulled out of the stomach, and we got to start all the way over again. So that duoderm is a way of securing that tube, patient's nose to their skin. That way, if they're moving around in their sleep, transporting them, or if they reach up and try to pull on it a little bit, it's going to stay fastened to the face, stay in place, hopefully, even though they can still pull it out if they pull hard enough. Hopefully, with that little bit of resistance, they're going to stop doing that. It's going to stay exactly where it needs to be. These things do get dislodged all the time, especially in pediatrics. I probably have done more mobile x-rays for NG tube placement because kids constantly pull them out of their stomach. Constantly. Daily. So we always, if you ever go into pediatrics, it's probably going to be your most common portable x-ray you ever do is NG tubes. Because they're always putting them in, they're always pulling them out. Constantly.
I will gladly keep doing her, though. So I'm super excited about this bag. When I travel,
all right, so primarily, even though we are going to do this sometimes, it is primarily the physician or nurse's responsibility to insert these into patients. But like I said, that does not always occur. Sometimes we have to jump in and do it ourselves. The patient will be most commonly placed in that Fowler's position to administer that tube. That's the most comfortable position. That's the easiest way to advance that tube. If you don't know what Fowler's position is, it's right here on the left where they're sitting up at an angle. The tube must be lubricated. Very important. Last thing we ever want to do is try to jam that thing down someone's nose and it's not lubricated. And it's getting caught up in their throat and you're really choking them. Must be lubricated to help it slide down a lot easier. And the patient will be instructed to constantly swallow. That's going to help that peristalsis occur. Peristalsis is that muscular contraction of the esophagus to help advance it, push it down. But do be advised, they may be choking as well. It's going to make it come back up. You got to work with that and keep trying to advance that. Say relax, swallow. So I know it's uncomfortable. Relax, swallow. back to that communication again. We've got to communicate very clearly, constantly with this patient. Try to give them comfort. Even though there's no way for that to be comfortable, as best you can, advise them to keep swallowing. Tracy, when they put yours in, did you have to keep swallowing, or did you just keep choking? How'd that work for you?
I had to keep on swallowing.
Yeah, it's. So did you? I got a question for you, Tracy. Did you feel it go all the way down into your stomach? Like, did you actually feel that tube go all the way down there?
I felt something.
Yeah, I'm just curious, like what that felt like going in your stomach. I've never had one, so I can't relate.
It was just basically uncomfortable in the throat. Everything else, like, once it like went down there, all I could feel it was in my throat. That's it.
Now, did it constantly? I mean, what I've been told is you constantly feel it back your throat. Is that true? Like it never goes away. You're always feeling it there. Yes.
Well, when they take it out, no. But like when they have it in, yes.
Well, that's what I meant. Yeah, what's in? What's in? That would drive
I
me.
have a question.
Yes.
Yeah, I know for nurses, they always have an order from the physician before inserting the NG tube. So what about us as technologists?
So that is something that the radiologist would give you clearance for. You wouldn't just do that. You wouldn't just start by yourself. And I'm sorry if I didn't say it earlier. If they did present to your room and the procedure you were doing required that NG tube, the radiologist would give you the clearance and the okay and the order for that. Yes. The radiologists do have the power to do that as a physician. Good question. All right, so Jessley did bring this up a second ago. If we are ever required to do this, every nurse always has a stethoscope, but the radiology departments also have stethoscopes on hand. The main way that most people check for a NG tube placement is they're going to use their stethoscope, put it on the patient's abdomen, and listen for what we call a whooshing sound. Something that you'll learn to listen for if you ever do this. That whooshing sound would confirm that tube is in place. And of course, x-rays. You're going to do, like I already said, 1 million of these x-rays to confirm this placement, because if you can't hear that whooshing sound, they're going to go ahead and do the x-ray to see where that tube actually sits within the stomach. And if it's right there directly in the stomach area, they're going to secure it. They're good to go. They can do whatever they need to do as far as the procedure requires. And as you can see in that GIF right there, the baby right there is wide awake. They're not sedated. They're going to advance that all the way down that baby's throat. And there is a technique to it, and it's something I can't really describe online. It's more like something you would have to describe on hand in the hospital. You got to be very careful when you're advancing that tube down the nasopharynx, because if you do it incorrectly, you can actually feed that tube through the patient's mouth from the nose. Like, it'll curve up the nose and out the patient's mouth, which, as you can imagine, will be very awkward and very uncomfortable. You got to make sure you advance that properly down that nasopharynx, down into the actual esophagus. Also, it's very important that they are swallowing, because if they're breathing, where's that tube going to go? Trachea. And you've got a really big problem there if you put the trachea. You can actually cause a lot of damage. So, not the easiest to explain, but if you ever have to do this, and you will at some point, you'll actually get the training to what to feel for. You can actually feel the tube where it's going a little bit as you're administering that little NG tube. Like I said, I can't really explain that online, but whenever you actually do it in person, you'll see what I'm talking about. But we are going to use that stethoscope to listen to that whooshing sounds, and we are going to use x-rays to confirm that placement as well. It's two main ways we're going to identify that that location of that tube is in the proper spot, which would be the stomach. Okay, and that's what a typical x-ray
What are you doing?
looks like. Do you have a question, Jonathan?
What do you need?
Oh, I was just gonna
What?
ask: do we ever do like aspirate the gastric
No, you're not on camera.
content
Camera's only
to
pointing
check
towards
to
the
see
chair,
if
man.
there is too, or are we just mostly gonna focus on X-ray and stethoscope?
Some nurses will do that because, I mean, obviously they're going to use it to draw fluid out anyway in a lot of cases. But the two primary ways we're going to do is the stethoscope and X-ray. That's not listed as a primary way to check, although you will see some nurses check it that way. Yes. Not always the most reliable either, because if you can imagine, a lot of these patients may present without any gastric contents in their stomach at all. So if we relied on drawing that fluid back and there's nothing in there, that's not going to help us anyway. So listening for that whooshing sound and using that actual X-ray would be a much more reliable means of checking that placement of that tube. But here is a KUB X-ray. Without me pointing to anything, can you guys see where the NG tube is located? Close look at that. See it right here? That will be our NG tube. So yes or no, is that tube in the correct spot?
Yes.
What do you think? Would you say yes?
Yes.
Looks like the stomach.
Because in our stomach.
I'm gonna say yeah.
It is. It is in the stomach. Now, a lot of nurses and techs and doctors would actually advance this more, because if you look closely here, I know we haven't went over this anatomy. This is the what we call the esophagogastric junction. It's very close to the esophagus, and that would be very close to becoming dislodged. Even though it's in the stomach technically, most people would actually advance that a little further. You'll actually see it start to curl in the stomach a little bit. I got pictures of what that looks like coming up. But even though this is correct, typically we would advance that a little bit more. So if you're ever doing this as a tech, my recommendation is if you see that tube right there close to where the esophagogastric junction is located, just to be safe, you want to advance it a little bit more, just to be on the safe side. Now that's more what it should look like right there. There's our tube coming down. You see it does coil just a little bit. Now it's hard to see the stomach, but we know the stomach is located in this general area. That's exactly where we want that tube to be. Now you see how it's curving quite a bit. This patient's stomach is shaped a little bit differently. That's why we have this major coiling going around here. If you do remember from body habituses, stomachs are not all shaped the same. So don't let it throw you off if you see a tube like this. The main thing you want to look for is for the tip of that tube to be in that stomach area right there, because we're in the right spot. Now this one right here. You guys see it? It's a chest x-ray instead of a KUB. They will often order chest x-rays. It just depends on what the preference is. Sometimes it's a chest x-ray, sometimes it's a KUB. Either one can show the stomach area because of where the location of the stomach is. So would you say it's a good placement or a bad placement? You're just going to look at that real quick. Good or bad?
I would say bad because it's curved, or is it supposed to be curved?
So I'm glad you brought that up. That's a key point. It is okay to be curved. And most of the time, these tubes will wrap around like we see right here. It's very common. That's why it's flexible. That's going to keep it in place even better. As opposed to if that tube ended right here, like I showed you earlier, on this picture, it's not curved. It's very close to the esophagus. It actually wouldn't be a very secure area because it's going to risk becoming dislodged out of the stomach and going back up the esophagus. Versus when it's coiled inside the actual stomach, it's a lot more secure overall. You got a little leeway should they pull that tube just a little bit. It won't become completely dislodged so easily. Out this one right here. This is on a baby patient. What's going on here? Good or bad?
They put it in the lung.
You are correct. They did put that in the lung. That's what I was talking about earlier, where one thing we got to learn is how to feel for where that tube is going and also monitor our patients and watch them very closely, especially if it's a baby and they can't communicate directly. They actually fed that tube through the trachea into the right lung. That can cause major damage and discomfort, as you can imagine. So it's something we got to be very, very careful and conscious about. This is someone that had no idea what they were doing. They actually could injure that patient's lung, especially with a baby, where that baby's a lot more fragile. And this does happen. This does happen quite often. So you as a tech, if you took an x-ray and you saw that, you'd want to communicate that immediately to a doctor or nurse and show that to them. And what's great is because we have these digital machines these days, these digital x-ray machines that are mobile, you'll see that x-ray pop up right away. Now, as an ethical technologist, you would not walk away and not say anything. You would bring this up to the nurse or the doctor because what are you? You're the patient advocate. You're the eyes. And the last thing we want to do is keep that in any longer than it should be. They'd want to remove that immediately and feed that tube back down properly. So if you ever see something out of line, remember, guys, you have the right to speak up. And I encourage you to speak up because you are the patient advocate. Do the right thing. Let them know what's going on so they can fix that issue very fast because that can cause major damage to that patient's lungs, permanent damage. Numerous conditions could occur for that, especially if they started trying to administer something before they check the placement, which some bad nurses have done that as well. As you can imagine, if they were administering some kind of liquid to that patient, they would fill those lungs up with liquid, cause a pleural effusion, cause all kinds of major issues. That patient could crash and possibly pass away. So very, very dangerous stuff. A simple procedure can have all kinds of repercussions if we don't do it properly, if we don't communicate properly. And there's one more right there. Does anybody know what's going on in this x-ray?
Are they injecting contrast through it?
They are injecting contrast. So this would be an example of what I talked about before, where if we have to use an NG tube for an upper GI, it would look just like that. It would actually push that contrast through that NG tube to fill up the stomach and do the proper procedure. Now, it is coiled quite a bit, but it is still considered within the stomach area. There can be instances where we advance this so far, and it's actually very hard to do. You almost kind of got to be lucky to do this because the opening to the duodenum is very small. This is very close to entering the duodenum, but not quite. Duodenum's actually over here. This is still within the stomach, and all this white that we see here, the picture's a little ugly, I apologize. There's all our contrast medium going to that patient's stomach right here. All right, so obviously, guys, it goes without saying, your patients that have NG tubes are going to experience, it says some discomfort, but I'm going to add they experience a lot of discomfort. I don't think it's a small amount of discomfort at all. And I think Tracy just confirmed what I'm saying with that. They're going to experience a lot of discomfort. So you must constantly communicate what's going on with them. Try to keep them relaxed. Try to keep them calm so they're not fighting with you. And never force that tube, guys. Just like anything we do, never force it. I mean, if you're getting a lot of resistance, give them a break, start over, advance from the beginning again. Let them take a big, deep breath. Let them relax. Because if you're fighting with that patient and you're trying to force that tube in there, not only are you going to just get nowhere fast, but what can you do? Cause damage to the patient. That's the last thing we want to do. That can have mega lawsuits on you. You can lose your job for something like that. Communicate. Do the right thing. Don't ever force it. And of course, if we're ever going to prevent accidental withdrawal on these procedures, guys, what are we going to add? What are we going to add to the patient's face? You see in that picture right there?
The duodenum tape or duodenum?
Duoderm. That's like duodenum. Yeah, duoderm. Make sure you know what that's called. It's a specialized tape called duoderm to keep it adhered to the patient. And you will see it done like this patient on the right sometimes as well. They actually wrap it around the nose. Not quite as comfortable. I don't like doing it that way. This is usually the preferred method we see on the left side here, the duoderm. And that duoderm comes in very large sheets, guys. If you ever see it in the hospital, you actually cut the size you want out of that sheet, and you can make it any shape you want. So it's not going to come with a nice little strip that you see here. It's actually going to be a large sheet of duoderm. You'll use some scissors and cut the shape that you need. You can make a triangle. You can make a square. You can make a circle. You can make an oval, whatever you want. If you want to make a star, make a star. But you get to customize how you want that duoderm to look when you adhere it to the patient. So they want like well, you could make a smiley face, but if they want a shape, you could make a shape out of it. They request a shape. But you would do that for pediatrics sometimes. You may see how that kind of stuff works great for kids. Hey, you want a star? Here's you a star. Okay, so non-ambulatory patient-only procedure coming up here. We're going to talk a little bit about the wonderful world of bedpans and urinals. And I'm going to say again, yes, we do have to use these quite a bit in radiology, specifically for non-ambulatory patients. If a patient is ambulatory, you would opt for actually escorting that patient to a restroom. But in the case of non-ambulatory, obviously they cannot walk. So there are proper ways we have to actually help our patients use the bathroom, should that occur, and when it does occur, because that will occur for all of you at least once in your career. Probably way more than once. Now, urinals. Urinals will be typically used for non-ambulatory male patients. For females, we're actually going to use a bedpan, which we get to next. Urinals are disposable. Now, you will see some patients, I don't recommend this. Some patients get really possessive of their urinals, keep them around for a really long time, and they reuse them over and over again. Now, my personal opinion, I would have them use it once and dispose of it, because as you know, urine becomes very stagnated very quickly. And let me tell you, from my personal experience, I've walked in on patients' rooms where they get really attached to their urinals. They don't dispose of them after using them multiple times. And if you ever smelled stagnant urine in a restroom that's never been cleaned up, it's going to smell with a very, very distinct odor. You're going to smell it as soon as you walk in that patient's room. Do them a favor. Ask them, can I dispose of your urinal and give you a new one? Because the hospital has millions of these things. Give them a new one because it smells really, really bad. Really bad. And you'll smell it when you walk into some of these patients' rooms because they're reusing that urinal over and over again. They're not cleaning it, and it should be disposed of. Now, it's typically going to be made of plastic. It's shaped the way it is so that a male patient can be lying supine on their right or left side, Fowler's position, really any position, and be able to urinate into that urinal properly. Now, obviously, there are times when a patient cannot urinate on their own. Let me answer your question before you ask it. Yes, you may have to assist a male patient or female patient in actually urinating. And there's a special way we do that, and that is considered a non-aseptic procedure. We're going to go over the steps for that coming up here next. By the way, if you ever want to play a really, really sick joke on somebody, I wouldn't recommend doing this as a student. I'd wait till you're a technologist first. But get yourself one of these urinals, put some apple juice in it, and walk around drinking out of it. And you'll get some really interesting looks from people. I can confirm I've done that once or twice just for fun, but you didn't hear that from me. You did not hear that from me. You know what? When you work night shift, you do some weird stuff. You're already kind of crazy because you're working night shift. That happened a lot on night shift when I would do those pranks. So
night shifts are the best, though.
I'm sorry. Say that again.
They're the best.
Night shifts are the best.
Yeah, I like them. I think they're.
I liked them before I had kids, and I couldn't during the day. So, yes, night shifts were great before I had kids. Okay, so take note, guys. Here comes the process for assisting a patient in urinating when they cannot urinate by themselves, because like I said, that will happen. You will encounter that, and we've got to be able to do it properly. So we are going to, this is talking about male patients, first of all, guys. We are going to expose the patient to permit adequate visibility. Obviously, you're not going to want to reach under the patient's sheets and start directing them to urinate if you can't see what you're doing. And that's just weird. You don't want to do that. You do need to go ahead and expose the patient. Now, when we talk about communication, guys, you're obviously going to communicate what you're doing and why you're doing it. Now, most of the time, they will ask you, hey, sir, ma'am, I need to go to the bathroom. Can you help me? Now, what would be the wrong answer? Oh, sorry, I'll go get your nurse. They'll help you with that. No, that's not the correct answer. You, as a technologist, need to step in and assist that patient with urination. That is one of your job responsibilities. So communication, guys, when they ask you, you're going to say, sir, ma'am, I'm going to pull your sheet back so I can assist you with urination. Say it just like that. I'll expose you so I can assist you with urination. You are going to spread the patient's legs and place the urinal between them. Then you have to actually place the penis into the urinal, guys, so it does not slip out. Otherwise, you're going to have urine flying all over the place. Actually direct the patient's penis into the urinal. Make sure you hold that urinal in place until they finish voiding. That's another way of saying urination, by the way, is voiding. Hold it into place. Make sure they are completely done. Ask them if they're done, by the way. Are you sure you are done? Because if you pull that urinal away and they're not done, you got a mess on your hands, and guess what? You've just caused yourself a lot more work because you got to help them change out the sheets and clean them up. So make sure they are completely finished before you pull that urinal away. Then, of course, you're going to remove that urinal. You're going to empty it. Remove your gloves. Wash your hands. Please wash your hands. And me personally, unless they are collecting the urine, because some patients, they're actually collecting the urine to measure it, I would dispose of it. I would not keep it around. That's my personal thing. Not everyone requires that, but I always dispose of them unless they're collecting the urine. Because like I already told you, they get really stinky, they get really nasty, and you're going to cause a lot of bacteria infections to form up in that room. I'm a bit of a germaphobe like that. I don't like to keep those things around. So once again, guys, it is very important. Put a star on that. You always want to confirm the urine volume. If that urinary output is being tracked, that is your responsibility, by the way. If you know the patient's urine is being tracked, and by the way, that's something you'd always want to ask the nurse before you left the room. Let's say you walked in, you helped the patient use the bathroom, you're done helping them. Before you dispose of that urine, always go find the nurse, say, hey, are you guys tracking the urine? If they say yes, give them the number, show them the urinal so they can write that down, because they are tracking that urine very, very closely. Don't just dispose of it before you communicate. If they say no, go ahead and dispose of it properly. And if you're me, go ahead and just throw the whole thing away. And you're going to dispose of that in the restroom. You're going to dispose of that in the restroom. And we'll say it one more time. You're going to dispose of that in the restroom. Why did I say that 3 times? Because I've worked with some really nasty technologists who just dispose of it in the trash. They just pour the urine directly in the trash. And a lot of patient rooms have sinks in them, right out in the open. I've seen them dispose of it in the sinks. Please, for the love of God, do not dispose of urine in the sink in the room. That's nasty. Put it in the toilet, please. Don't even put it in the sink of the restroom. Put it in the toilet and flush it, please. I'm not trying to be funny. That has happened. Like I said, I've worked with some really nasty techs in my 10 years as a tech at TCH. I've seen some weird stuff. And of course, guys, it goes without saying, please wash your hands. I don't care if you were the cleanest person on earth helping with that urination, with that urinal, whatever. Wash your hands when you're done. And provide the patient hand washing so they don't get bacteria on their hands. You want to walk away if they got pee all over their hands, help them clean up. Give them some wipes. Help them walk over to the sink and wash their hands if they have to. Or, of course, they can't walk. Provide them with actual wipes to clean their hands. Whatever you got to do, assist that patient. Keep it as clean as possible. And this is an example here, guys, by the way, on the right. Does anybody know what's different about this urinal? What's different about that urinal than the one I showed you earlier?
This is a female urinal.
Correct. So a lot of hospitals don't have these, but some facilities do have what's called female urinals. They are shaped very similar to a male urinal, but they're designed to accommodate female anatomy for them to urinate in a urinal in that way. But most places will have a bedpan for females, which we're going to go over next. But do be aware, if you ever see one that's shaped like that is a female urinal, don't use that on a male. And vice versa. Don't use a male urinal on a female. Make sure you know the difference between the two. Otherwise, you're going to have a big mess on your hands. Okay, so bedpans are going to be used for defecation and for urination for women. So you don't want a male to urinate in a bedpan. You're going to use a regular urinal, but you are going to use these for defecation of both sexes. Yes, you will have to help people defecate. That does happen. I see you all scrunching up your faces right now. Yes, that does occur. Yes, that does happen. And you do have to assist that patient to sit on that bedpan, do it cleanly. Yes, you have to help them wipe themselves in many instances. Yes. Don't just leave them dirty. Help them stay clean. And obviously, without saying, guys, a bedpan is always disposable. Don't throw that dirty deadpan. Don't throw that dirty deadpan in the corner. Expect them to reuse that thing. You're not going to reuse a bedpan after you defecate in it. That's not going to happen. Now, I don't have to restate this, guys. It's obviously common sense. Gloves and hand washing extremely important, especially in the realm of feces. Make sure that you are washing your hands before and after. Make sure you're assisting that patient before and after to wash their hands. Assist them on that bedpan. Make sure they're sitting on the bedpan. Make sure they're sitting on the bedpan, please. Otherwise, they're going to poop all over the bed. And the last thing you want to do is clean poop up off of a bed. Many techs have done that quite a bit because they're not paying attention. Help them out, especially grandma or grandpa. Make sure they're aiming for that bedpan properly, sitting on it properly. You're talking to them. You're assisting them. You're not making faces, by the way, because defecation can be noisy. It can be smelly. It can be messy. I'm just going to put it plain, especially if a patient has diarrhea. Don't embarrass them by scrunching up your face and going, oh, my God, oh, my God. Oh. Why do I say that? Because I've worked with techs that have done that as well. They make faces. They make noises. And obviously, if you were in that patient's shoes, you would not want the tech or nurse or whatever helping you, making weird faces when you're trying to use the bathroom and you can't help it. Amy, were you about to ask a question? I saw you unmute.
Yeah, I don't know if I'm asking it right. Aren't there some exams where you have to analyze the poop? Like, what would you do in that situation? Like, would you keep the poop in there, or what do you do?
I'm glad y'all are so inquisitive about poop today. Now, I talked about poop with the seniors yesterday because we talked about defecograms. Just to give you an insight on that, a defecogram is a radiologic procedure where we watch patients poop with contrast. That's the easy way to describe that. They were making the same face as you guys were. But yes, Amy, to your point, there are instances, much like urine, where they will collect feces. That's, once again, why you want to communicate properly with the nurse. Hey, just to make sure, are you guys collecting the fecal material for analysis? They say yes, you will put it to the side or just hand it to the nurse, whatever. They'll put it into an analysis bag and send it to the lab. If no, you will dispose of that bedpan immediately. But yes, they do keep it sometimes. But yes,
do we do this? Like if it's a portable X-ray, is like the time that we offer our help, or is it like something that we will do kind of like rounds if we need like to go help, like if they're short staffed or something?
Oh no. So basically, to answer your question, is Betty, basically if you walked into a room doing a portable X-ray and Grandpa's saying, "Hey, it's Betty, I've really got to use the bathroom. Can you help me?" Then yes, you would step in and assist. You're not going to walk in and just start putting people on bedpans and watching them poop and doing rounds and doing analysis. Only if you walked into a room and they asked you for help, essentially, which happens quite often in the hospital environment, especially when you're doing a lot of patients. That's going to happen at some point. They're going to ask you, and the wrong answer would be to say, "Let me go get your nurse, go run away." You as a tech are a healthcare worker, therefore you must assist that patient if they're asking you to assist them. Don't punt that off to somebody else. It's going to give you a bad reputation, and it's just not your duty as a technologist to punt that off on somebody else. And it can happen in your X-ray room. They like with the urination, they walk into your X-ray room, or they're on a stretcher because they can't walk. Say, "Hey, it's Betty, I've got to poop. I need some help." You're not going to say, "Oh, I'm sorry, I can't deal with that right now." You got to wait till after the X-ray and do it in your room. Because you know why? If you try to make them hold it, especially if they're having issues and diarrhea, you got diarrhea all over your X-ray table now because they couldn't hold it. And I don't know about you, because I have cleaned up feces in an X-ray room. And if you know how an X-ray table is designed, all that fecal material will get into those cracks and crevices and circuitry. I don't think I need to explain how much of a nightmare it would be to clean that. In fact, they're probably going to call someone in to dismantle the table to clean it. You don't want to find yourself in that situation.
Just curious of how it works. It's fine. I mean, it is.
No. I know. I'm just trying to hammer the point in that when they ask for help, guys, it's going to save you a lot of trouble. On that same subject, if you told that patient to wait, like I said, I've really got to do number 2. I've really got to use the bathroom. I've got to defecate. I got to poop. Whatever they say. They'll use some other choice words as well. They'll just be very blunt with you. You don't want to say wait. You're doing a KUB X-ray in a portable machine in a patient's room. You're doing a KUB, which goes under the patient, by the way, under the abdomen. You said, "I'm sorry, you got to wait till your nurse comes in." They can't hold it. And guess what? They just release diarrhea all over your X-ray cassette. And once again, I don't know about you, but I don't want to be wiping poop off my X-ray cassette or my machine. And then I got to clean up the whole bed. I got to clean up the whole patient. And I don't like cleaning up poop. I'm going through 3 kids now and change 1 million diapers and seen so much poop that I never want to see it again. So do yourself a favor and help that patient out. You're going to call yourself, you're going to prevent yourself from having a big disaster and a lot more trouble as far as cleaning all that up, because it will be a big mess.
Mr. Donahue, one more question.
Yeah.
You know how you said that normally a technologist, so I mean, if they're in that situation where they have to help the patient assist them when they're defecating, when they have to keep the feces, do they just hand it to the nurse in the urinal, or do they put it like in a special?
So
And they handle it?
that depends. The nurse may ask you to assist them on this, or they may just take care of it themselves. You're to communicate with that nurse, and most of the time they have a biohazard bag that they're going to go ahead and dump it into, and that's sent to a lab. So you may actually assist them in dumping that in the bag, or they may just do it themselves. It depends on what they ask you to do. They would be put in a biohazard bag. Yeah. Yeah.
Thank you. Sorry for the question. This is on you to me.
No, I'm glad to answer. So how many of you, when you joined this X-ray program, knew you was going to be handling some poop? They don't put that on the brochure, do they? No, but it does happen. It's being a healthcare worker, guys. You gotta get used to it. You're gonna deal with poop, feces, and vomit. I'm sorry, it's the truth. Aurora, did you have something you were gonna ask?
Do they collect diarrhea too?
Yes,
I don't know.
they
It's
do.
just a question. Oh,
Yes,
wow.
they do.
That sounds like really messy.
It is. It's wet and wild. Just to put it bluntly. Yes, they do. It depends on what they're looking for, Aurora. Sometimes they do. Yeah. Okay, so moving on here. I know we're having fun talking about poop here, but let's move on a little bit more. 2 days in a row I've talked about poop. What do you know? Respect the patient's privacy and comfort, guys. Obviously, if a person is having to use the bathroom in front of you, it does not come easily. People that are anxious or nervous, it may take a while. Be patient. Don't say, hey, I need you to hurry up. Hurry up. Come on. Just let it go. Let it go. It's okay. Just let it go. Just ease them into it, guys. Say, it's okay. Relax. I know it's difficult. Take your time. I'm not in a hurry. Even if you are in a hurry, you're going to say, I'm not in a hurry. It's fine. Is there anything I can do to help you feel more comfortable? Would you like me to put a sheet over you? Whatever you can do to help that patient relax, do it. There are two main designs for bedpans. The standard is going to be 2 inches high, which you see right there in that picture. Typically, they're colored pink. They will be other colors sometimes, but the most common is that pink color right there. And we have what's called fracture pans. They're a little bit more shallow, and they are contoured for patient comfort. It is used for the exact reason of what you see within the word. A fracture pan would be used on a patient that has a very bad fracture, like of their femur, for example, of their back. They can't move. They're in a lot of pain. That fracture pan is designed to give them a little bit more comfort because they'll be having to use the bathroom while laying down. They can't sit up. So it's going to accommodate the fact that they're laying supine, they're very injured, they're hurting, but they can still use the bathroom as best as possible. As best as possible. You'd have to have assistance for a patient like that, by the way, especially if it's a larger patient, to help lift them up, put the pan under them, put them back down, let them use the bathroom, lift them back up, pull the pan out, make sure they're clean, so on and so forth.
So I have a question. What if you have a 600-pound patient?
Good luck. No, in that case, it's going to take a team to help that patient. Do not ever go in there and try to do that by yourself, guys. Even a 200-pound patient, guys, it all goes back to that key word of communication. Don't be afraid to ask for help. Don't go in there and break your back, pull a muscle, hurt yourself. If you need help, say, hey, my patient needs to use the bathroom. Can you guys come help me lift them? People will come and help you. They will come and help you. Don't ever try to do that by yourself. You will hurt yourself.
Mr. Donahue? So,
yeah.
Okay, so you said for these ones, right? Like the plastic ones, you can dispose it, right? So
yes.
For the metal one, so how does that work? So they're gonna put that for it's like sterilization?
For the what? Sorry?
For the metal ones?
The metal? Yeah, they will typically put those on. They will sterilize those and reuse them, but that's pretty obsolete these days. They don't really use those much anymore. I think a lot of older hospitals would still utilize those. That's kind of the old way they did it. Most of the time, they're going to use these disposable ones, at least from what I've seen. And that's what a fracture pan would look like, guys. Like we just said, you're going to have to make sure you have assistance to lift that patient up, put that pan right underneath them. By the way, you know why I like this picture? This is a great example of what not to do. What is wrong with this picture?
Look like the gown is on top of the pan.
Thank you, Daniel. I'm so glad you said that because that's the exact right answer. Please, guys, don't just throw that pan under there and say, go at it, go have fun, get to use in the bathroom. Make sure you assist them to move that gown out of the way, because I don't think I need to describe what's going to happen if they start using the bathroom and that gown's covering the bedpan. Guess what? It's not getting in the bedpan. It's getting inside the gown, and you're going to have a big mess to clean up. Pull that gown out of the way, help them out, because the patient's not going to know a lot of times, especially if they are on extreme pain meds and very numb. Help them out. Do yourself a favor. Because do I gotta draw some artwork here? You're gonna have all kinds of junk here. It's gonna leak onto your X-ray equipment. It's gonna get all over the sheets and these little crevices. I'm using blue, so it's a little less gross, but you get the idea. All right, barium enemas. Barium enemas are a very common procedure that we as techs will do. It's a quite common procedure done in fluoroscopy. Essentially, a barium enema is a fluoroscopy exam where we use contrasts to diagnose pathologic conditions of the colon or the lower gastrointestinal tract. We're going to fill the entire large intestine up with barium. We're going to do that by administering a rectal tip with a tube and a bag of contrast hung above the patient. It's going to allow that contrast to flow through the tube into the rectum and fill that colon up backwards, essentially. They're never going to drink contrasts, and we're never going to visualize the colon in the natural process like that. This is done in reverse, through the rectum, through that entire large intestine to fill it up with contrast and air a lot of times as well, which we'll go into that in a second here. Some alternatives to a barium enema would be what we call a colonoscopy, a virtual colonoscopy, and a sigmoidoscopy. Most of you have heard of a colonoscopy. Most men have to get these done. Most women have to get these done when they reach a certain age to look for polyps, colon cancer. This is usually done sedated. We're not going to go too far into colonoscopy, but most of you already know what that is. That would be a cancer screening. Also, with barium enemas, they can be done as cancer screenings if a colonoscopy is too expensive for a patient. So if they come to a hospital for a cancer screening, they can't afford the colonoscopy, they could opt for doing that barium enema. And that leads me to my story.
I was going to say that.
Oh, yeah, Tracy, you've heard the story. Yeah, you've heard the story. So that leads me to my story. My first job in Lake Charles, Louisiana, was as a very small country hospital, little county hospital for people that did not have medical insurance, much like Ben Taub and LBJ, same kind of thing, but much smaller scale. It was a 30-bed hospital, very tiny. Well, we had what was called the barium enema room. Barium enema room was where you did barium enemas all day. That's all you did. And it was a cancer screening room because these patients could not afford colonoscopies. They would come to our hospital to get barium enemas, do that cancer screening. So this is my very first day as a technologist, by the way. My very first day. I just got my license. I just got me a nice job. I was excited. Chipper young tech, ready to show the world what I was made of. And I get thrown in the barium enema room for my first day. Common thing, it was almost like a hazing. They always threw you in there for your first day. So my first day, my very first patient is this woman who is very obese, like morbidly obese, could barely walk. I'm talking about 400 pounds. So we get the exam set up. Everything is good to go. We get the tip inserted. Doctor comes in. He's ready to start the procedure. And we start administering the contrast, which that's where we let that contrast start flowing from the bag down the tubing into the patient's rectum. Oh, by the way, I forgot to say this. When you insert the tips, they inflate what's called a balloon. They insert that tip and inflate a balloon. That's going to be important to my story, by the way. They inflate a balloon in the rectum to keep it in place. Otherwise, the patient would push it out because obviously you're going to be pushing. You're naturally going to be trying to push that out of your colon as that procedure is going on. That balloon keeps it in place. So we start administering the contrast. It starts flowing in. The patient is on her left side. Yes, her left side. And she starts making a lot of noise, like a lot of discomfort, like, oh, it hurts, I can't hold it. So we're trying to tell her, calm down, ma'am, relax, take big, deep breaths, try not to push too hard. You're doing great. The procedure's almost done. You're doing a great job. Keep breathing. So she keeps making a lot of noise, and she keeps moaning and groaning, saying, it hurts. Well, you've ever had an experience in your life where you face death in the eye and everything goes in slow motion? This is a very similar experience. Have you ever seen a movie where everything happens in slow motion? Everything went in slow motion all of a sudden, because all of a sudden I hear a loud noise, like a suction popping noise. So I hear this noise, and I look to the patient. I'm right behind her, by the way, with her backside facing me. I hear this noise, and all of a sudden I see the barium enema tip flying towards my face. And when I say everything went in slow motion, it went in slow motion. So me, being my chipper young self, decided to do some Matrix moves. Have you ever seen the Matrix where they're dodging bullets? I try to dive out of the way really quick to get out of the way of this tip that's flying towards my head. Now, luckily, the tip did miss my head, but it did not miss the rest of me. It hit me on my side and went all over the side of my body and down my leg. So I got this tip, just got barium all over me, nasty barium from inside her colon. By the way, when I talked about the balloon being inflated, she blew this thing out with the balloon still inflated, by the way. The balloon was still fully inflated, which is about this big. She blew that thing out with the balloon inflated. So I'm sitting here disgusted because this junk's all over me. Meanwhile, there's barium flying out of her backside like a waterfall, getting all over the table, getting all over the fluoro tube. She's moving around, so the barium's spraying everywhere. There is white barium and fecal material, by the way, because she was not cleaned out very well, all over the place. So I looked to the radiologist. His name was Dr. Louvier. He looked at me. He's like, well, we're done with this procedure. And he walks out. He just walks out. Meanwhile, I'm standing there with barium and junk all over my clothes. There's barium and fecal material all over the table, all over the floor, all over this woman who's still moaning and groaning in pain. And I'm like, oh my God, what do I do? So I helped the woman get off the table, and I mean, she's just covered with this stuff. It's all over the place. I help her walk to the restroom. I say, ma'am, go ahead and use the bathroom. Try to push the rest of that out in the toilet. Take your time. Please take your time, because I didn't say this, but I got to clean up a lot of this mess. Take your time and eliminate the rest of that barium. I'll come back and check on you in a little bit. Okay, so while she's in the bathroom, she's in there making all kinds of noise, by the way. It's quite loud. I don't think I need to fill in the blanks there of what noises are going on. I'm trying to clean this mess up. I mean, because it is like a flood. I mean, it's horrible. Because we administer a lot of barium on those studies. A lot of barium, 3,000 milliliters, as a matter of fact. So I'm cleaning everything up. I mean, it's going to take me hours to finish cleaning this up. So she finally finishes using the bathroom. She goes ahead and walks out. She's cleaned up. She's dressed, and she goes along her merry way. Okay, ma'am, I tell her the process. You might have a white stool for a few days, discomfort. Thank you. Have a nice, healthy day. Goodbye. So I finally finish cleaning up the fluoro room, which takes me forever. And I'm thinking to myself, well, I better check on the bathroom, because I'm sure she made a mess in the bathroom as well, because this stuff was going everywhere. Are you ready for this? Because I don't think you're ready for this. I walk into the restroom, and first thing I see is there's barium and feces all over the toilet. Okay, I expected that. But it's also all over the floor. It's also all over the sink. It's also all over the walls. And then, just like you would see in a cartoon or a movie, I look up above me, and there is barium and residue on the ceiling. True story, on the ceiling. So I'm sitting there with my broken mind, and to this day, I still don't know what happens. Did she point her butt straight up in the air and launch this at the ceiling, or did she throw it up there, or what happened that defied physics and got that on the ceiling? So long story short, it took me forever to clean that as well. To this day, I still don't know why that was on the walls and the ceiling and everywhere, what she was doing in there. But who knows? Maybe I'll make a discovery someday and figure that out. That is my first day as a technologist. One day I will never forget. Don't let that scare you about barium enemas. That does not happen very often, although messes can occur, obviously. But yeah, that left an impact on me. It goes without saying. That's my barium enema story. Very scary experience, very traumatizing experience, and to this day, I still don't know what happened, how it got on the ceiling. But who knows? Who knows? Hope she's doing well. Hope she's doing well.
Did this happen to Jackie once last year?
To Jackie?
But with the mail? Yeah.
I think something similar, but not quite, where he shot a tube out and it made a really bad mess. Like he really bared down hard and it made the tube fly out. I have to ask her again. I think it was a little bit similar because I remember she was laughing about that because I told the story first and it happened to her. Something similar. Yeah. So, lesson, guys, when you're doing a barium enema, stay out of the line of fire because you never know when these things are going to launch out of someone's rear end. Do yourself a favor, have lots of towels nearby, lots of cleaning supplies, because even though it doesn't happen a lot, should bad things happen and there's a bad mess, you'll have the tools to clean up your room properly. But let's get back on track here. That's the end of my story, my barium enema experience. Got lots more crazy stories like that, by the way. You haven't heard anything yet. I could write a whole book on weird stories in radiology. Lots more to come. That's just the beginning. Okay, this picture here is showing you what a typical barium enema procedure would look like. You are going to be inserting a tip into the patient's rectum. I'm sorry, this is actually a colonoscopy. I apologize. This is a colonoscopy procedure. They're done very similar, by the way. They're going to administer a tube through the patient's colon. This is a camera that you see right here that goes all the way to the cecum. And they're going to be able to look at all the inside parts of the colon, check for polyps, check for any kind of cancerous lesions, things going on. And they can actually go in there and remove the polyps as well with a specialized tool that's attached to that camera. And this right here is what we call a CT colonography. Sometimes if you go into CT, they do similar procedures that they do in radiology, but it's going to be a much more enhanced version. They would do a CT colonography to get an actual 3D reconstruction of the inside of the patient's colon. How would they do that? They'd actually have the patient have barium administered rectally, much like a barium enema. Only difference is they would go through a CT machine, and the CT will get a lot more data and actually create an entire 3D reconstruction of the inside of that colon. The doctor could actually go in there and dissect and look at piece by piece and do some analysis on. Now, even though this is really great technology, one thing we always got to remember is CT is much higher dose. So even though the technology is great, they would only opt to do this if there's something really bad going on and they need a much better view as opposed to a regular barium enema. Because CT does offer much higher dose, and you're going to increase the chances for there being effects on that patient later in life. So even though it's really cool, not done too often, it's more so an emergency type procedure that is performed. And then a sigmoidography. Sigmoidography is simply where we're going to do an analysis of the sigmoid region of the colon, much like a colonoscopy, but it's only going to be advanced forward into the sigmoid colon area, very close to that descending colon. It's only going to examine the lower third of the colon, sigmoid colon specifically. And even though these are very messy procedures, once again, they're still falling under that category of non-aseptic techniques that we may be involved in. Sometimes you may be involved in these colonoscopies, not very often, but they may require fluoroscopy for a colonoscopy, especially if they can't see where their camera is exactly, or they're having trouble advancing it, to make sure there's nothing in there obstructing that camera. Okay, I think it's a good stopping point right now, guys. I've got about 6 minutes left. I'm going to go ahead and stop right here. So on Friday, we will finish up this chapter. We're going to talk a little bit more about barium enemas specifically, such as the type of tools we'll use, how we prep our patients, what to look for, and what we will see. and how that all applies under non-aseptic technique categories. I will send you the PowerPoint so far in your email. Are there any questions about what we talked about today? Any questions? Yeah, go ahead.
So okay, so you know how you said we're gonna do the NG tube, like if we can, but are we gonna do the practicum for that or not?
Not for NG tubes, no.
Mr. Donahue, I know you said we're not gonna go that deep into colonoscopy. And the book has some sections about the virtual. Do you want us to focus on that too?
Just know the different types of colonoscopies there are, yes, but don't feel like you got to know the entire procedure, all the really fine details. We're going to go more so into barium enemas in detail because that's something you're going to be more directly involved with more often. Anybody else? All right, guys. Well, I will see you all at 1 o'clock. Enjoy your extended break today. And I hope you enjoyed learning all about poop and feces and urine today. And I hope you enjoyed my story. There's much more where that came from that I'm going to share with you guys. But take care. I will see you all at 1 o'clock. Goodbye.